Do you think cases caused by genetic or chromosomal disorders pose a challenge in regular practice? Identifying multiple congenital anomalies in a scan is okay, but what is the final diagnosis? What would you advise a couple having a previous child with a genetic or chromosomal anomaly looking for preventive options? What about ethical concerns related to conditions such as autism spectrum disorders? Do Mendelian laws of inheritance apply to all genetic and chromosomal conditions? Do all anomalous reports mean bad news? And finally, do you feel that you need a basic idea about genetic counseling and genetic testing yourself so that you may be able to better provide options related to management for a high-risk pregnancy? Hello, I'm a genetic counselor at Fetomat Foundation, Kolkata. I offer genetic counseling to patients who present their concerns related to chromosomal or genetic disorders. I offer preconceptional genetic counseling, pediatric genetic counseling, and counseling in prenatal settings. Genetic counseling is not just endless explanations about a genetic or chromosomal anomaly. This profession is also confused sometimes with other professions such as being a clinical geneticist or a clinical psychologist, which we are not. Very few genetic counselors exist in our country of 1.3 billion people. So this makes us a very rare breed. And with the rise in technologies of genetic testing strategies, there is an increased demand for genetic counselors in our country. No doubt, our primary aim is to interpret, educate, and counsel about genetic and chromosomal conditions, but our main function or role is to create awareness both amongst the medical professionals as well as your patients whom you refer to us for genetic counseling or testing. But before I go into certain details with regard to what I do, I want you to let go of your uneasiness regarding genetics in practice and join me and see what I do in my world of genetic counseling. Now, you already know about the cell and how it houses the nucleus, which contains the hereditary material of our body, the DNA. The DNA is a huge molecule. It's about 2 to 3 meters in length. And when it is tightly packed in coiled and supercoiled arrangement within the nucleus, there are 23 strands of it. It is known as the chromosomes. Now you can see the chromosomes by a simple test known as the karyotype test, which is present in the nucleus in the cell. 23 pairs of it can easily be viewed. In the case of a human male karyotype, which you can see on the screen, there is an X and a Y chromosome along with 22 body chromosomes, which we call autosomes. And in the case of a female, the X and Y are replaced by only 2 X chromosomes. Now, any change occurring within a chromosome, such as a balanced translocation, it can be viewed by the karyotype test. That is known as a chromosomal aberration. Any genetic change occurring within the genes is known as a mutation, and that can be understood by a genetic test. Truthfully speaking, human genetics is caused by problems occurring within the chromosomes and the genes. Chromosomal aberrations can occur due to structural or numeric changes within the chromosomes. Structural changes include a balanced translocation, which usually we find in about 50% of the cases in patients who present with early pregnancy losses. A balanced translocation carrier is going to be normal or healthy individual. The problem happens when the unbalanced part of the chromosome is inherited by the fetus or the pregnancy. In that case, 2 conditions can occur. 1, the fetus might not be viable with life and be lost as an early pregnancy loss. Or 2, if the child is born, he or she would suffer from multiple congenital anomalies from birth itself and would be leading a dependable life. The other type of chromosomal aberrations we get to see in the cases are numeric changes occurring within the chromosomes. Your most important and your most common form of chromosomal disorder with a numeric change is actually Down syndrome, or we call it trisomy 21, which occurs because of the occurrence of the extra chromosome 21 along with the normal 1 pair of it. Deletions are the other kind of chromosomal numerical changes. A common one is your Turner syndrome, 45XO is the karyotype. You can actually look for these numerical and structural changes in the chromosome via simple tests, the karyotype test, or the FISH analysis, which is fluorescence in situ hybridization, and the microarray or array CGH. When it comes to genetic conditions, there are about 25,000 to 30,000 genes in the human body. Out of that, research tells us, around 9,000 to 10,000 genes are pathogenic or disease-causing. Single gene disorders usually follow the Mendelian pattern of inheritance. Like you have the autosomal dominant pattern of inheritance, in which there is a 50% risk associated for the condition to happen in future pregnancy, males and females equally likely to be affected. In an autosomal recessive condition, there is a 25% chance for males and females to be affected in the future pregnancy. In X-linked conditions, firstly X-linked recessive, there is a 50% chance that males are likely to be affected, and in an X-linked dominant condition, there is a 50-50 chance for both males or females to be affected in a future pregnancy. Looking further into a gene consists of parts as well. Each part of a gene is known as an allele. There are some conditions which are caused due to many alleles being mutated together. For example, hearing loss, which is a condition that is resulting from a biallelic or two alleles being mutated. Upon investigation of a particular disorder, you might find that a certain chromosomal or genetic condition has occurred by chance or as a spontaneous event in that pregnancy only. These cases have a very low recurrence risk pattern. A less than 1% risk is involved. However, if there is something called germline mosaicism or a certain mutation occurring within the sperm or the ovum, then in that case an additional 3 to 5% recurrence risk may be involved as well. Such cases are known as de novo mutations. Now, multifactorial inheritance poses a challenge. Looking into conditions like autism, diabetes and hypertension, there might not be just genetic or chromosomal factors involved here. There might be other contributing factors as well. That is why these conditions follow multifactorial inheritance, because factors such as maternal inheritance, maternal complications, chromosomal or genetic problems, environmental and lifestyle issues may also play a role. In these cases, recurrence risks are not enough. For this, we provide empiric risks, in which case, considering the fact that a couple has a child with autism. So, empiric risk for the second child to have autism spectrum disorder is around 10%. And empiric risk for the third or the fourth child to have the same condition is around 35%. Now, in cases where couples approach you for future pregnancy planning, let's take certain situations. For example, if they have a child with an undiagnosed but suspected case of a chromosomal or genetic disorder, in that case, what would you do? Now, in case of a child who is living and affected, we would first look into his condition, whether it is chromosomal or genetic. In case the condition is genetic, then certain tests such as genetic testing, gene sequencing or next generation sequencing tests are looked into. If in case the child presents with a chromosomal problem, we would look into tests such as microarray or karyotype or FISH analysis. A karyotype test, as I explained earlier, would help look into any changes or structural or numeric changes occurring within the 23 pairs of chromosomes. In case we are looking for a FISH test, a fluorescence in situ hybridization, then we would be using certain probes to identify the microdeletion or microduplication that has happened within that part of the chromosome. You can look for conditions such as velocardiofacial syndrome, Dijot syndrome, Prader-Willi syndrome, Williams syndrome, etc. using a FISH test. In case you're opting for a microarray test, in this case, little changes, very small changes known as copy number variations can be picked up in the report, and then result interpretation is going to be done. Once the genetic or chromosomal problem has been identified, you can talk about referring your patient to a fetal medicine specialist who would be offering prenatal diagnosis options related to chorionic villus sampling or amniocentesis at the appropriate gestational ages. If you're looking into the second clinical scenario, where a couple had a previously affected child and they have stored the blood sample or the DNA sample. In that case, tests can be offered for the stored DNA or blood sample, whether it is chromosomal or genetic, appropriate testing will be offered. And then for future pregnancy planning, prenatal diagnosis options can be discussed with the fetal medicine specialist. Now, in case of a couple having a previously deceased child with a chromosomal or genetic problem, but no stored blood sample or DNA available, in that case, a thorough family pedigree is going to be able to tell us whether the problem in consideration is either autosomal dominant or autosomal recessive, or X-linked dominant or recessive, or a completely different form of inheritance altogether. If suppose the family pedigree tells us that the condition is suspected to be autosomal dominant, then we will look into testing of the affected parent who is suspected to have the condition. If we are looking into an autosomal recessive condition, then we can talk about carrier testing for both the parents. If the family pedigree tells us that the condition that we're looking into is probably X-linked, then in that case, the mother is likely to be unaffected if it is recessive X-linked disorder. For that, we can talk about carrier testing for the unaffected mother. If the condition is X-linked dominant, then the mother is also likely to be affected, and testing can be offered to confirm the mutation before prenatal diagnosis options can be provided. At Fetomat Foundation, I help to offer preconceptional genetic counseling, prenatal genetic counseling, and pediatric genetic counseling for a number of genetic and chromosomal anomalies. During preconceptional genetic counseling, I address couples who are interested in planning for a future pregnancy for conditions such as a bad obstetric history where they have multiple pregnancy losses, one after the other, a karyotype report having a balanced translocation identified in either one of the couple. If the couple are carriers of a particular genetic disorder, such as beta thalassemia, they would want to know about their recurrence risks associated. Another common concern is whether or not a child is likely to suffer from a disorder that has occurred in the previous child. And finally, in cases where they want to find out about recurrence risks associated with a genetic condition running in the family. During prenatal genetic counseling, I offer counseling related to an ongoing pregnancy. If suppose the expectant mother is of the advanced maternal age, meaning more than 35 years of age or equal to 35 years, there can be certain risks for Down syndrome and other related chromosomal disorders, which makes it a high-risk pregnancy. Now, prenatal genetic counseling can also be offered for an anomalous maternal serum screening result. For example, certain findings of high-risk problems in first trimester or second trimester biochemical screening result. In case of an abnormal fetal ultrasonogram, the condition can also be identified whether it is chromosomal or genetic based on the findings that is presented within the scan. A combined first trimester scanning and biochemical testing may be positive for high risk. In that case, prenatal genetic counseling can also be offered to talk about options related to prenatal diagnosis. Prenatal genetic counseling also involves thorough discussions regarding options related to prenatal diagnosis, such as chorionic villus sampling or amniocentesis for a previously identified mutation. In cases where pediatric genetic counseling is offered, for example in the case of a living child with a chromosomal or genetic problem, first of all the clinical diagnosis has to be confirmed if it is not done so. After the diagnosis is confirmed, the appropriate form of testing, genetic or chromosomal, is offered. Once the mutation has been identified and the condition has been confirmed in the child, it is important to confirm the clinical diagnosis in an affected child via genetic testing or chromosomal testing. This helps us to offer symptomatic therapy and management for the clinical symptoms presented by the condition, and a multidisciplinary approach is usually offered in such a case, where there is a team of doctors and specialists who get together to discuss on how to go about the management of the symptoms presented. Once the mutation is identified, prenatal diagnosis options can be discussed with the fetal medicine specialist for this affected child. In case of a deceased child, carrier testing for parents can be offered and explored. Genetic tests are not easily available as an off-the-shelf basis, or where one can usually just walk into a center and expect a genetic test to be carried out. There is a strict protocol to be followed when it comes to genetic testing, and usually the terms and conditions are fulfilled by offering pre-test and post-test counseling. During pre-test counseling, the genetic counselor will make sure that all the information, limitations, and associated challenges associated with the test are well understood by the legal guardian or the person who is affected with the genetic condition. During a genetic test, certain terms and conditions have to be met as well. For example, taking consents. Consent has to be taken for the person who has been affected with the genetic condition. If the person is a minor, a legal guardian gives the consent, the father or the mother. Consent also has to be obtained from the referring physician or the genetic counselor. And finally, all this has to be done in the presence of a witness who would sign at the moment of the testing. In case of improperly filled consent forms or incomplete ones, it may lead to complete rejection of the test on part of the laboratory. Post-test genetic counseling is probably the most important part of genetic testing because this involves detailed interpretation of the results obtained in the test. Queries and concerns related to the test are also addressed here, and if there is any requirement for further testing, that will also be mentioned. If there is any availability of symptomatic therapy and management of the condition, that will be mentioned. And finally, it concludes with psychosocial counseling. So let us focus on integrating obstetrics and gynecology with genetics and fetal medicine. This is unfulfilled potential, lying the same as it is for the past so many years. The world is moving rapidly towards advanced technologies of the post-genomic era. So let's not just sit back and relax to brace the impact of it. It's time that we got together to finally embrace it, so that we are privileged to offer the best possible solutions and testing strategies to every high-risk pregnancy. After all, it's never too late to start.